Signs. Herniation is a lethal complication. Subdural hematoma, collection of blood underneath the dura. Blood covers the surface of the brain due to tearing of bridging veins that lie between the dura and arachnoid. Usually arises with trauma, crescent-shaped lesion on CT, presence with progressive neurological signs. Increased rate of occurrence in the elderly due to the age-related cerebral atrophy, which stretches the veins. Herniation is a lethal complication. So herniation is a displacement of the brain tissue due to mass effect or increased intracranial pressure. Tonsillar herniation involves displacement of the cerebral or you could say cerebellar tonsils into the foramen magnum. Compression of the brain stem leads to cardiopulmonary arrest. Subfalcine herniation involves displacement of cingulate gyrus and under the falx cerebri. Compression of the anterior cerebral artery leads to infarction. Uncal herniation involves displacement of the temporal lobe uncus under the tentorium cerebelli. Compression is from the cranial nerve 3. Oculomotor leads to the eye moving down and out and dilated pupil. Compression of posterior cerebral artery leads to the infarction of occipital lobe. Contralateral homonymous hemianopsia. Rupture of paramedian artery leads to the direct brain stem hemorrhage. Now, demyelinating disorders. Basic principles are myelin insulates axons, improving the speed and efficiency of conduction. Oligodendrocytes myelinate and the central nervous system. Schwann cells myelinate the peripheral nervous system. Demyelinating disorders are characterized by destruction of myelin or oligodendrocytes. Axons are generally preserved. Leukodystrophies. This is one of the demyelinating disorders. Inherited mutations in the enzymes necessary for production or maintenance of myelin. Metachromatic leukodystrophy is due to a deficiency of aryl sulfatase. Autosomal recessive, most common leukodystrophy. Sulfatides cannot be degraded and accumulate in the lysosomes of oligodendrocytes, and lysosomal storage disease. Crab disease is due to deficiency of galactocerebrosidase. Autosomal recessive again. Galactocerebroside accumulates in macrophages, and adrenoleukodystrophy is due to impaired addition of the coenzyme A to long-chain fatty acids X-linked defect. Accumulation of fatty acids damages adrenal glands and white matter of the brain. Multiple sclerosis, autoimmune destruction of CNS myelin and oligodendrocytes. Most common chronic CNS disease of young women or adults 20 to 30 years of age, more commonly seen in women. Associated with HLA-DR2, more commonly seen in regions away from the equator. It presents with relapsing neurologic deficits with periods of remission, multiple lesions in time and space. Clinical features include blurred vision in one eye, optic nerve, vertigo, and scanning speech mimicking alcohol intoxication, brainstem. Internuclear ophthalmologia, or you could say ophthalmoplegia. Medical, it's medial longitudinal fasciculus. Hemiparesia or unilateral loss of sensation, cerebral white matter, usually periventricular, lower extremity loss of sensation or weakness, spinal cord, bowel, bladder, and sexual dysfunction. Autonomic nervous system diagnosis is made by MRI and lumbar puncture. MRI reveals plaques and areas of the white matter demyelination. Lumbar puncture shows increased lymphocytes, increased immunoglobulins with oligoclonal IgG bands on high-resolution electrophoresis, and myelin, basic protein. Gross examination shows the gray-appearing plaques in the white matter. Treatment of acute attacks include high-dose steroids. Long-term treatment with interferon beta slows progression of disease. Subacute sclerosing panencephalitis, progressive debilitating encephalitis leading to death due to slowly progressing persistent infection of the brain by measles virus. Infection occurs in infancy. Neurologic signs arise years later, like during childhood, characterized by viral inclusions within neurons, gray matter, and oligodendrocytes, which is white matter. Progressive multifocal leukoencephalopathy. JC virus infection of oligodendrocytes, white matter. Immunosuppression like AIDS or leukemia leads to reactivation of the latent virus. Presence with rapidly progressive neurological signs, visual loss, weakness, dementia, leading to death. Central pontine myelo or myelinolysis, focal demyelination of the pons, the anterior brainstem, due to rapid intravenous correction of hyponatremia, occurs in severely malnourished patients, alcoholics, and patients with liver disease. Classically presents as acute bilateral paralysis, locked-in syndrome. Dementia and degenerative disorders. Basic principles: characterized by loss of neurons within the gray matter, often due to accumulation of proteins which damages neurons. Degeneration of the cortex leads to dementia. Degeneration of the brainstem and basal ganglia leads to movement disorders. Now that brings us to Alzheimer's disease. Degenerative disease of cortex, most common cause of dementia. Clinical features: slow onset memory loss, begins with a short-term memory loss and progress to long-term memory loss, and progressive disorientation, loss of learned motor skills and language, changes in the behavior and personality, patients become mute and bedridden. Infection is a common cause of death. Focal neurologic deficits are not to be seen in the early disease, but most cases are sporadic and seen in the elderly. Risk increases with age and doubles every 5 years after the age of 60. And E4 allele of apolipoprotein APOE, in short, is associated with increased risk. E2 allele with decreased risk. So these are the different genes. Early onset of Alzheimer's disease is seen in familial cases associated with Presenilin 1 or Presenilin 2 mutations. Down syndrome commonly occurs by 40 years of age. Morphologic features include cerebral atrophy with narrowing of gyri, widening of sulci, and dilation of the ventricles. Neuritic plaques, extracellular core comprised of alpha-beta amyloid with entangled neuritic processes. And beta amyloid is derived from amyloid precursor protein APP, which is coded on chromosome 21. APP normally undergoes alpha cleavage. Beta cleavage results in alpha-beta amyloid, and amyloid may also deposit around vessels, increasing the risk of hemorrhage. and neurofibrillary tangles, intracellular aggregates of fibers composed of hyperphosphorylated tau protein. Tau is a microtubule associated protein. Loss of cholinergic neurons in the nucleus basilis of Meynert. Diagnosis is made by clinical and pathological correlation. Presumptive diagnosis is made clinically after excluding other causes, confirmed by histology at autopsy when possible. Vascular dementia or vascular dementia, multifocal infection and injury due to hypertension. Atherosclerosis, vasculitis, second most common cause of dementia. So, given by the name vascular dementia, you should know that there would be an infarction or an injury due to vascular system related problems. Pick disease. Degenerative disease of the frontal and temporal cortex spares the parietal and occipital lobes, characterized by round aggregates of tau protein, peak bodies in neurons of the cortex. Behavioral and language symptoms arise early, eventually progresses to dementia. Parkinson's disease, its degenerative loss of dopaminergic neurons responsible for dopamine in the substantia nigra of the basal ganglia. Nigrostriatal pathways of basal ganglia uses dopamine to initiate movement. Common disorder related to aging seen in 2% of older adults. Known or common disorder related to aging seen in 2% of older adults. That is something we know, but unknown etiology. Historically, rare cases were related to MPTP exposure, a contaminant in illicit drugs. Clinical features: TRAP, T-R-A-P, tremor, pill rolling tremor at rest, disappears with movement, rigidity, cogwheel rigidity in the extremities, echinacea or bradykinesia, slowing of voluntary movement, expressionless face or mask face, postural instability and shuffling gait. Histology reveals loss of pigmented neurons in the substantia nigra and round eosinophilic inclusions of alpha-synuclein, like the Lewy bodies, in affected neurons. Dementia is a common feature of late disease. Early onset dementia is suggestive of Lewy body dementia, which is characterized by dementia, hallucinations, Parkinsonian features. Histology reveals cortical Lewy bodies. Huntington disease, of course, degeneration of GABAergic neurons in the caudate nucleus of the basal ganglia. Autosomal dominant disorder, chromosome 4, characterized by expanded trinucleotide repeats, CAG or cage. It's basically CAG. So in the Huntington gene. Further expansion of repeats during the spermatogenesis leads to anticipation. Presence with chorea that can progress to dementia, depression. Average age at presentation is 40 years. Suicide is a common cause of death in Huntington disease. Normal pressure hydrocephalus. Increased CSF resulting in dilated ventricles can cause dementia in adults and usually idiopathic. Presence as triad of urinary incontinence, gait instability, dementia, wet, wobbly, and wacky. Lumbar puncture improves symptoms. Treatment is ventricular or peritoneal shunting. Yeah. And it brings us to spongiform encephalopathy, which is important. Degenerative disease due to prion protein. Prion protein is normally expressed in CNS neurons in an alpha helical configuration. Disease arises with conversion to a beta-plated conformation. Conversion to can be sporadic, but inherited familiar forms of disease are transmitted. But pathological patterns, the protein is not degradable and converts normal protein into pathologic form, resulting in vicious cycle. Damage to neurons and glial cells is characterized by intracellular vacuole, spongy degeneration. Creutzfeldt-Jakob disease, CJD, is the most common spongiform encephalopathy and usually sporadic but rarely can arise due to exposure of the prion infected human tissue, human growth hormone, or corneal transplant. It presents as rapidly progressive dementia associated with ataxia like cerebral involvement, and myoclonus might be included, but periodic sharp waves are seen on EEG, results in death, usually in less than 1 year. Variant CJD is a special form of disease that is related to exposure to bovine spongiform encephalopathy, which is mad cow. Familial fatal insomnia is an inherited form of prion disease characterized by severe insomnia and an exaggerated startle response. Which brings us to CNS tumors. Basic principle can be metastatic, 50% are primary. Metastatic tumors can be present as multiple well-circumcised lesions or lesions at the gray-white junction. Lung, breast, kidney are common sources. Primary tumors are classified according to cell type of origin: astrocytes, meningoendothelial cells, ependymal cells, oligodendrocytes, or neuroectoderm. In adults, primary tumors are usually supratentorial, but most common tumors in adults are glioblastoma, multiforme, meningioma, and schwannoma. In children, primary tumors are usually infratentorial. That's important, remember. Most common tumors in the children are pilocytic astrocytoma, ependyoma, or medulloblastoma. Primary malignant CNS tumors are locally destructive but rarely metastasize. Glioblastoma multiforme, GBM. Malignant high-grade tumor of astrocytes. Most common primary malignant CNS tumor in adults usually arise in the cerebral hemisphere, characteristically crosses the corpus callosum butterfly lesion. Characterized by the regions of necrosis surrounded by tumor cells, pseudo-palizzating endothelial cells proliferation. Tumor cells are GFAP positive and poor prognosis. Meningioma, on the other hand, benign tumor of arachnoid cells. Most common benign CNS tumor in adults. More commonly seen in women, rare in children. May present as seizures. Tumor compresses but does not invade the cortex. Imaging reveals a round mass attached to the dura. Histology shows a whorl pattern. Zymoma, bodies, and may be present, but let's move to schwannoma. Benign tumor of Schwann cells. involves cranial or spinal nerves. Within the cranium, most frequently involves cranial nerve 8 at the cerebellopontine angle, presents as loss of hearing and tinnitus. Tumor cells are S100 plus, so bilateral tumor are seen in the Neuro, fibromatosis type 2, and oligodendroglioma or malignant tumor of oligodendrocytes. Imaging reveals a calcified tumor in the white matter, usually involving the frontal lobe, may present with seizures, phatic appearance of the cells on biopsy, and phylocytic astrocytoma, benign tumor of astrocytes. Most common CNS tumor in the children usually arises in the cerebellum. Imaging reveals a cystic lesion with a mural nodule. Biopsy shows rosental fibers, thick eosinophilic processes of astrocytes, and eosinophilic granular bodies. Tumor cells are GFAP positive, so medulloblastoma are malignant tumor derived from the granular cells of the cerebellum, and neuroectoderm usually arises in children. Histology reveals small, round blue cells. Homocyte rosities are may be present, but poor prognosis. Tumor grows rapidly and spreads via CSF, so metastasis to coda equina is termed drop metastasis. Which brings us to ependymoma, where malignant tumor of ependymal cells usually seen in children. Most commonly arises in fourth ventricle, may present with hydrocephalus, perivascular pseudorosities are a characteristic finding on biopsy. Craniopharyngioma is a tumor that arises from epithelial remnants of Rathke's pouch, presence at the supraanterior mass in a child or young adult, may compress the optic chiasm leading to bitemporal hemianopsia, but calcifications are commonly seen on imaging, derived from tooth-like tissue, benign, but tends to recur after the resection.